from South Carolina, so we don't learn how to talk without walking. I have to do it simultaneously. I know that'll be annoying to some of you, but I can't help it. It's ingrained culturally. So the other thing I think to mention is that my first big boy gig was as a peer support specialist in New York City in 1995, working with people who are homeless and diagnosed with an opioid use disorder or some other co-occurring disorder. So I sort of cut my teeth early on, and that would also be to tell you all that I'm a person in long-term recovery as well. I completely agree that it's so important for people who have that story to discuss it. I tell it to the medical students, pharmacy students, anybody who will listen, and it's so interesting how many people will pop into my office and say, "Hey, Dr. Spieth, can I talk to you a little bit?" It just opens the door for people to get open. So I try to make things interactive. I know this is going to be a little bit hard, but I like to do that anyways. So who in here in this room, by show of hands, has ever had some kind of expert, AKA a provider, physician, marriage counselor, somebody like that, tell you some advice or make a recommendation to you? Okay, so what looks like about all of you, how many of you all adhere to that advice regularly? Yeah, define regularly, right. So that's my little way of building empathy. Yes, I'm not exactly trying to equate stopping using crack or alcohol or heroin with flossing your teeth. But what we know about human behavior is behavior change is hard. And even when you know, many people in this room probably know that you're engaging in behaviors that are very harmful and can take years off of your life, but it's challenging to stop, right? So I think it's kind of important to appreciate how hard change is when you're thinking about other people's process. And also, we think about drug use outcomes, and you hear a lot about how drug treatment's not effective, right? And is there room to improve? Definitely there's room to improve. But if you compare substance use treatment outcomes with other outcomes that involve behavior change, like managing diabetes type 2, asthma, things like that, they're pretty similar. So I think the idea here is that these changes are hard, and therefore it's important to have empathy and compassion for people who are suffering from them, while also obviously trying to improve. I also agree with what's been said before. There's a lot of focus on opioids nationally at the state level, the county level. That's really important. I'm kind of optimistic to a fault, though, that I hope that this does also lead to better awareness of alcohol problems, cocaine problems, crack problems, benzodiazepine misuse, all of those types of things, because we have a drug problem in our society, not just an opioid problem. Or at least that would be my argument. So I'm going to go through this really quickly. I'm going to use the medical students gave me a really nice analogy for this. So agonist therapy, which is methadone, which was mentioned a little bit earlier. Agonist therapy basically means that the methadone binds to the opioid receptors fully, right? So it's like a puzzle piece that fits in completely, and therefore mimics the endogenous opioids that we have. And that's where I sort of cut my teeth with the methadone treatment. There's a lot of evidence to suggest it's very helpful for people. It's not the right medication for everybody, but it's helpful for people, though, like was mentioned earlier, it's not widely accessible because of some of the regulations. Then we get into Suboxone, which is the partial agonist buprenorphine, and the naloxone, which is an antagonist. So essentially the partial agonist really means it's a puzzle piece like we do in my family. It doesn't quite fit, but you try and mush it in anyways, just to get the puzzle completed. So it doesn't fully activate that receptor, but it does to some degree, but also binds, not allowing other opioids to connect. The antagonist, the naloxone, is really on board so that people, trying to prevent people from injecting it and things like that. So that's the Suboxone. And then lastly is the antagonist, which we think of as naltrexone. And essentially that's another chemical that binds to the receptor, but it has an opposite or an effect to where the opioids then won't work. So if you're attempting to use an opioid while you're using naltrexone, you're not going to feel it, essentially. So I think why I present this is to say there's not one right medication for every individual. And I think, like a lot of things in our life, people need options to determine what makes the most sense for them. I'm going to cut through that. So I'm going to talk a little bit about the effectiveness of medication-assisted treatment, but I ask you all first. So if you're thinking about drug treatment, what outcomes do you care about? If you had a loved one, family, just community member who went into drug treatment, what would you hope happens when they come out? Just yell at me. Not die. So not having an overdose, right? What does someone else say? Stop using. Okay, and so stop using, be a little bit more specific. Okay. What's that? Sobriety, okay. Any other things that you would hope somebody would accomplish or an outcome that you would see when someone completes drug treatment?
And recovery.
What's that?
Recovery.
Yeah, recovery, and would that involve family, children, things like that?
Work, family.
Yes.
Personal purpose.
Yes, exactly. Yeah. So recovery is multifaceted, right? Like we heard so well earlier. It can be a variety of things to a variety of people. I think many of us would sort of define recovery as being alive would be one thing. Having an intact family, being a productive family member, potentially working, volunteering, being an active member of the community, and not using other illicit substances. So I had a feeling those are some of the things that y'all were going to say. So I have some research that sort of supports those outcomes with Suboxone in particular. Well, first of all, what does the research say about comparing extended release naltrexone, again, that's the antagonist, versus Suboxone? So this is a large study, got a lot of publicity in this field in 2018, where they randomly assigned folks and they looked at them for 24 weeks. Basically, what they found, you can read the slides, but I'll just kind of overview. What they found was that folks had a harder time engaging, having the extended release naltrexone induction. So what that meant was that less people got the medication, and therefore that group's relapse rates were somewhat higher. So what to think about with extended release naltrexone is that there needs to be a period of sobriety for the person from opioids before they can take that medication. That's not as easy as it sounds, and it doesn't sound easy, right? So the person needs to basically say, okay, this is my day, I'm gonna stop, and then somehow they need to be in an environment or have the support around them where they can make it 3 to 5 days without using opioids to then get the extended release naltrexone. That's not realistic for all people, I would argue, and that's not realistic for all communities where there's maybe not even somewhere for them to go. We hear stories about people breaking windows at Burger King so they can go to jail for a few days and get sobriety. Like that's the measures that people will go through sometimes to be able to do this. Whereas the Suboxone inductions were much easier because the person didn't have to wait that period of time. They really just had to be in a mild withdrawal from opioids before using that medication. So it's easier, right? But once people had the medications, the recovery rates were pretty similar. So I think the idea is to think about when you have specific folks that you care about, what's realistic, what does the community provide, what would make sense for that person. So this is an interesting slide, I think, as well. This talks about how medication's not the only answer. The research is still trying to figure out what the right combination of psychosocial treatment and medications are for each individual. Like, for example, people who are diagnosed with PTSD and a co-occurring substance use disorder seem to benefit from a integrated cognitive behavioral therapy that involves PTSD treatment and substance use treatment, but that's for that group, right? And then there's certain folks who seem to benefit from 12-step meeting attendance in combination with medications, but the science is still really trying to figure out what's the best option for people. But this is a study, it's not a randomized trial, but it was a population of people who identified as Black or African American. There were 300 folks, and they were Suboxone patients, and they were at a federally qualified health center. And essentially what these slides suggest is that folks who were engaged in treatment were much more likely to attend 12-step meetings than those who split treatment, which makes sense, right? And we could argue, well, they were just more invested or what have you. But that combination of being involved in medication-assisted treatment and doing 12-step attendance seemed to be working. And where we see it works is below there, the group of people who were sober of this group, they were attending significantly more 12-step meetings than were the group that were not attending as many meetings. And the really interesting thing is that if you'll notice, that's not only sobriety from heroin, but also cocaine. So what that leads me to suspect, and other people suspect, is that although Suboxone is not indicated as a tool to help people abstain from cocaine, when people engage in treatment, some of those other substances are going to become off board as well because they're in the system. They're beginning to think about themselves as a person in recovery, right? So this is, someone talked about mortality, right? Which is, I would argue, an outcome that's important. This is a huge study in 2018, and basically what this slide suggests is that folks who are involved in Suboxone were significantly less likely to have an all-cause mortality. So all-cause mortality means that could be overdose, that could be I wrecked my car while I was using, that could be I fell off the roof and, whatever, it's all-cause mortality. They're significantly less likely, the folks who were using Suboxone or extended-release naltrexone, than folks in that untreated period. So you got 4.89 per 100 had some kind of all-cause mortality death when they weren't being treated versus 0.26 per 100 and 0.93 per 100 for the two other medication-assisted treatments. And then the overdose mortality, so if you want to clean out the car accidents and the other types of things that would lead to death for people, the contrast is still quite striking. So it's 0.24 people per 100 who had some kind of overdose mortality while engaged in MAT versus 2.43 per 100 for the untreated period. So again, and this is a huge study, and this one got a lot of attention too. It was thought to be pretty rigorous from a scientific perspective to demonstrate that it seems that offering people access to these medications can really prevent overdose or make it less likely than people who are not getting that treatment. These are a couple more studies on that vein. France has been, and really our European friends have been sort of at the forefront of Suboxone treatment and addressing opioid use disorder in general. And in France, they recently made the decision to just take away many of the regulations associated with people getting Suboxone, so that physicians or nurse practitioners or PAs didn't have to go through as extensive of a training, as well as making it much more accessible for patients to access and making it much more widely available. And they found a 79% decrease in overdose over the 3 years following that change. And they didn't see an increase in other types of problems that would be, thought about societally. And then lastly, this is in Massachusetts, so closer to home. I was going to make a comment about the food. I can't say Massachusetts food is probably good too. You kind of think of France as having food. But anyways, this was a 2018 study. And they found that there were the 1,700 folks in the Massachusetts. Basically, what this study did was people who had survived an overdose and were in a hospital, right? Some of them engaged in MAT, some of them did not. And what they found was those who engaged in MAT after that overdose were significantly less likely to have a mortality-based overdose than the folks who did not. So that's kind of like the overdose literature. Child welfare. So child welfare is really near and dear to my heart because I worked a lot in the child welfare system in Cuyahoga County. And in particular, the intersection of people with mental health issues and substance use issues who were engaged in the child welfare system. This is still pretty new literature, and there needs to be more studies on this. But basically, the questions people wonder are, does a family who's been in some way touched by the child welfare system, are they more likely to have good outcomes if the parent, caregiver has access to Suboxone? And so this was a study that looked at, and so there were 55 families. Only 9% of those families had access to MAT, and in this study that was both extended-release naltrexone and Suboxone. And 541 that doesn't make sense. Oh, gotcha. 596 total families, 55 MAT, 541 did not. They argued that the reason why there's such discrepancy is that in that area there just wasn't as much access to MAT in general, which is why the numbers are so small. But essentially what they found was that the families who had access to medication-assisted treatment, and this I think is incredibly important, the children were more likely to remain in the household. They were less likely to go to out-of-home placement. And that each additional month increased the odds by 10% that child would stay in that family. So that to me, I think ultimately what we know about the child welfare system, people do the best they can clearly when children are out of home placement. But what seems to be is if the family is healthy enough to maintain custody of that child, the outcomes are going to be better for everyone on the societal level, the costs associated and the burden with, but also the research with children specifically. So then this is another one. This was in Canada, kind of an interesting study. They were looking at, this is more longitudinal studies. They were tracking data from 1 year before offering, and this was an indigenous community, 1 year before this indigenous community had access to medication-assisted treatment. So they were tracking data then, and then 1 year after this indigenous community had access to medication-assisted treatment. And they're kind of looking at, okay, well, how does their availability of Suboxone improve or not, right? Those families' outcomes. So they found that for those families involved, that the police criminal charges fell by 61%. That's one thing I didn't hear about was law enforcement outcomes, but I see a lot of law enforcement here and first responders, and I'd like to tell you all thank you for your service while I'm up here. It's a hard job, and y'all are a key part of this and have a lot of the burden associated with it. So we would, I think, hope that if people have access to drug treatment effective, they're less likely to break the law, right? So that was, this study suggested that happened. Child protective services cases fell by 58%. Again, that's an important outcome we just mentioned. School attendance, kind of important for kids to go to school, right? Increased by 33%. It's interesting, like okay, why do we care about people getting the flu shot, not the flu shot? It's kind of like a proxy for a healthy family, right? Like if you're an intact family, you're probably more likely to get your kids a flu vaccine than if you're a family that's flying by the seat of your pants and having significant challenges. We can't necessarily say, yes, of course they're healthier, but that's kind of a proxy for that, right? 350% more likely. That's kind of impressive, right? I think so. But what we do, have concerns about, I gotta watch my time. So about like diversion, which is an issue, and misuse. So I just try to disentangle this a little bit. So misuse is basically you're using your prescription but incorrectly. So, I'm a patient, I get Suboxone, for whatever reason I'm injecting it, right? Which people do. That would be misuse, but not diversion. Diversion would be, I'm a patient, I have Suboxone, and I'm giving that to my neighbor, right? So that's diversion. One thing I just want to say is that as a society, we divert medications all the time. Yeah, they're not necessarily, medications like Suboxone, but societally, we give away our medications, we take other people's medications, and this data sort of suggests that. They do these surveys where they call people and say, are you taking other people's medications? And people say, yeah, I am. So basically, I think societally, we have kind of this belief that it's not harmful, and therefore I think some people therefore don't think that diverting their medications is a big deal. No, we would argue it is. What about an MAT? So patients involved in medication-assisted treatment studies suggest that somewhere around 15 to 20% of them may divert their medication at any given time, which doesn't mean that they have a side hustle where all they're doing is diverting their medication. But it means that what the research would show is that, for example, there's a bad batch of heroin going around my county, like what happened in Cuyahoga a few months ago, where a large number of people died, right? People divert their medications in that situation to people who aren't in treatment because they don't want them to get that quote unquote bad batch. We can all say that's not what we want to happen, right? But that's some of the rationale. And there's ways that providers, and I'm sure they do this at town hall too, can take steps to make it less likely that diversion is going to happen. Maybe, to be real, again, this is not, I'm condoning this, but it may happen occasionally, but what we really want to curb is people who are diverting their medications as a full-time job and not engaged in treatment at all. So cut to the end. So what ways to divert or to reduce the diversion of medications? So urine tests, frequent urine tests, and where you're looking for not only buprenorphine in the urine, right? That means they're taking it, but also the buprenorphine metabolites. And why you do that is because sometimes people do dip their buprenorphine into their urine, and then it looks like they actually took the medication. The metabolites is harder to fool, right? Pill counts and medication log. So you have people come in a contract, a good contract, you say, I have the right, if you're gonna be in my practice, I have the right to call you and you need to be here within 24 or 48 hours and drop urine and also provide your medication. And the person then agrees to that or doesn't agree to that, and then you can do that, right? Observed ingestion, which we heard about from Town Hall 2, and especially, early on, but also, people that you're concerned about having them come to your office 3 times a week if you have the capacity and doing an observed dosing. Giving limited medication supplies, that can really help with decreasing diversion. If people don't have many medications, then they're not going to have as much to divert if that's what they're trying to do. Obviously, using the Ohio Automated Prescription Reporting System, you have to do that if you're a provider, but just to put that up there. You can also certainly think about these new ways of ingesting buprenorphine, which is the extended release injections and the implants. I hope people haven't figured out a way to divert those medications yet. There's a way sometimes, but I've not heard of anybody doing that as of yet. And then obviously looking to make sure that the dose that you're giving is adequate for people. So sometimes what may happen is a person may say, I'm still feeling somewhat sick, so I'm not getting enough medication. That could be true, right? Or it may not be true. But there's some instruments like the CALS, which of course now I forget what that acronym stands for. But where a provider can look at a person objectively and determine, okay, no, it seems like this is the appropriate dose for you, or this isn't the appropriate dose for you. So there's things that you can do because you want people to not have too much medication, right? Because then again, they may be diverting that medication. For children, it's very important for, anybody who's going to have anybody coming into their home, but especially children. As a provider, it's very important that they have had a plan in terms of how are they going to safeguard that medication so that people can't get access to it, and particularly children. And then obviously where you can, reinforcing positive behavior. That's something we forget about sometimes, but throwing people a bone when they're complying with treatment and doing well is good. In the Suboxone world, that might be the person can come less regularly to appointments, right? If that's what they see as valuable. Some people like the appointments though, so it's hard to, you have to check that out with the person you're working with. Treatment agreements, like I mentioned, collaborating with other providers. So this is where that integrated care is so important. Folks can learn a lot from pharmacists, counselors, Division of Children and Family Service caseworkers, having the opportunity to check out with people. Do people seem like they're in recovery? Having access to full psychosocial treatment. Family, I mentioned, is incredibly important in terms of helping around diversion, but also just adherence to medication. And appreciating the person's rationale for diverting before acting, but then acting based on that rationale. So those are my references. So I thank you all very much. So I'll wait for Dr. Pierre to get here. But think about what, if any, questions y'all have for either of us or both of us. Yes, Miss.
Certainly, I've come to understand Suboxone is an effective treatment protocol, and that it may not be subject to overdose because it's less widely available than other drugs. But I've also recently read that Suboxone itself is addictive. Comment on those reasons.
I'll let you jump in there first, and then I'll.
Suboxone is a narcotic. I shouldn't say Suboxone, buprenorphine using the generic term, is a narcotic. It is used in the treatment of pain management. It too has an addictive potential, but it is much less than that of either the opioids that we're familiar with, like fentanyl, Vicodin, Percocet, things of that nature. Keeping in mind that these are almost logarithmic when you go from something like morphine to heroin to fentanyl is 50 to 100 times stronger, to carfentanil 1,000 times stronger. That's the elephant anesthetic you've all heard about. We just had a case in the emergency room somewhere in Northeast Ohio where the police officer and numerous emergency room people were affected by the contamination of the scene with the suspect is carfentanil. So yes, it has an addictive potential, but when you combine it with the naloxone, as Dr. Spieth was talking about, you have this sort of balancing effect that makes it much harder for them to abuse it. It becomes addicted to it. And I hope that answers your question.
But the fact that that's leads to overdoses, it's clinic is only primarily administered clinically and is less available publicly.
I really can't speak to how available buprenorphine is on the street. There is the version that goes with that. I'm actually thrilled to see it's 18%, I think. I was concerned of it being much higher. I've had people divert diabetes drugs in my office. Why, I don't know, but they do. I think they can resell them on the market. But are we going to cure? Are we going to get to 100%? I don't expect that. I don't have any disease that I'm hoping for that other than, things like cancer and things of that nature. But in this disease, right now, we're making incremental progress.
Yeah, the last thing I would just say is, that, if people do not, in terms of the addictive question, if people have opioid use disorder or taking buprenorphine-Naloxone, Suboxone, and if they stop taking it, they're going to feel sick, right? And that's part of the rationale is that they can take this medication and avoid feeling sick and be productive. Which is why people, you have to think about when and how somebody gets off, if they get off. The other thing I would say is it's not nearly as psychoactive either as some other substances that were mentioned, so that people can take Suboxone and be very productive in their life. So when you think about recovery, I think about being able to be productive in my life. And many people use Suboxone and are incredibly productive, probably some people in this room, and do all the tasks associated with having a healthy life. Yes?
So how long does someone stay on it? Is it forever?
That's an individual question. We always say, this is not to be snarky, but how often, how long do people stay on their diabetes medication, right? So it's kind of a similar answer though. For some people, the goal is to get off at a certain point, right? For other people, that may not be their goal. And if they're successful in their life in all the ways we just described, good parent, good citizen, those type of things, and it's helping them, then it may not be indicated for them to get off. So it's a very individual answer. And typically that's a collaborative discussion with a provider.
I agree. We like to learn by case studies. I'll give you a brief one. Before I was into this, before I was coroner in my office, 30-something-year-old patient, after 2 years of getting to know her, very quiet, always reserved, admits to me that she's been taking Suboxone for 5 years. Because trust is important. We know that our patients are watching our faces, watching our responses, understanding, trying to figure out how we feel about what they're going to tell us. And she tells me this. And I said, well, are you troubled that you're on it for 5 years? She said, I'm not on heroin anymore. I will tell you that she is the manager for a national restaurant chain that covers Michigan, Northern Ohio, Western Pennsylvania. She has 2 children. Her partner, her boyfriend is still addicted. But that was a mind changer for me.
So I want to be mindful of time. We are at, I don't want to interfere with y'all's lunch. I know I don't like to get in between people and food. It is noon, so, but we can take questions.
I'll be here if you want to stop up, Dr. Spieth, we'll be here. Thank you all.
Yeah, thank y'all.
Thank you.